dear colleagues, dear friends, it's one way, it's kind of a mixed feeling. It's a great pleasure for me to talk to this symposium, and also a sad feeling because Professor Povodovnyuk is no longer with us anymore. And that's why I think it's very important to make this contribution. And I hope that you will appreciate this lecture from above to some extent. So let me start my lecture about TBS. I will share my screen and I will go through this presentation about TBS in clinical practice. So as I said, TBS, let's talk about TBS into the clinical practice and one step further, because I already present some cases to you guys for quite a while. And today we'll try to go one or two steps further, and that's what we want. So first of all, as I say, it's really in memoriam of Professor Povodovnyuk. And I just realized that it's been many years. I've been a very close friend of Ukrainian people, and I still have many friends there. And I cherish that relationship. It's very important. But I also realized that, you know what, I got hundreds of pictures and I couldn't decide. So I have to almost do a random pick and just select few here. On different occasions, at different time, I came to Ukraine, in Kiev, in Bukovel, in Yaremche, in Liev, or Odessa, some others. And I think that was a small token that I could do to Vladislav, just to show some of them here. And I really love that pictures here on the left side, because it's really him when he can just really relax and really a guy who really enjoy being surrounded by friends, and that was important. So the topic of the TBS and my talk will be clinical benefit of TBS, best practice of TBS in 6 takes, few clinical cases, and then at the end, if you still have time, question and answer. So the rules is really every time I can be a bit provocative, a certain approach, but we'll try to be logical towards clinical practice. But every time you see this logo, there's a Swiss flag, that it means based on a clinical experience or opinion rather than official guidelines. So the clinical benefit of TBS, first, osteoporosis is a matter of low bone mass decrease and deterioration of bone microarchitecture leading to a fracture. But the problems that we know that both are needed. Unfortunately, we had no clinical tool today to speak to bone architecture. Why we know osteoporosis is a major problem is one osteopic fracture every 3 seconds. The cost is huge worldwide. We talk about 124 billion worldwide. And we also know that about 50% of major osteopic fracture are occurring in a non-osteoporotic zone, as it is right now. We also know that treatment exists and it can reduce by 50% the fracture risk, and sometimes up to 85% for vertebral fracture. But we also know that unfortunately, more than 50% stop the treatment after 18 months because they're not always convinced of the efficacy, or they just by bad habits. So having said that, as I said before, the BMD is a current gold standard. And unfortunately, 50% of the major osteopath fracture occurred in a non-osteoporotic zone, as you can see here. So you clearly have a relationship between fracture density, but it's not all. And you can see here, you can have exactly the same density, the same bone mineral density as a areal density, but the underlying structure might be quite different. And this one here will be more fragile, more solid than this one, because the structure plus the density are needed to have a better assessment of the risk of fracture. So the idea is just to go more than just density, and actually we should almost talk about bone strength. But the bone strength is a complex concept, and that you obviously have the bone quantity, but in terms of bone quality, you have the bone turnover, you have mineralization, you have a microstructure and microstructure, and that's where we'll focus here is really on the microstructure assessment. And that's where the TBS come in. The TBS stands for Trabecular Bone Score. It's an FDA-approved software installed on DEXA machine or even on workstation that work mostly on a regular PA spine DEXA scans, but soon you'll be able to do that also on the hip, also based on X-rays, as we were able to do sometime also on VFA, as we're publishing right now with Professor Neil Binkley. So TBS has been shown to be associated to bone microarchitecture. Now it's really clearly demonstrated. And the most important, that it provides information that is additive to BMD and clinical risk factors. So that means it's not a surrogate of BMD, it's just additive to BMD, so that together with clinical risk factors, we do better than if you were having only one or the others. The concept here is, again, thanks to a specific experimental diagram that's been modified, we can, from a 2D image, extract some structural information which is related to the microstructure. And even if you have the same BMD, then you can have an idea about the underlying structures. And if you have a high TBS, that will mean a correlation with a good structure. If you have a low TBS, then that will mean a poor structure. So that's the bottom line of the TBS. Here, just to show you a very nice study that was done with Henri Recht a couple of years ago about demonstrating the strong correlation between TBS and the structural parameters from a bit more than 100 bone biopsy at the iliac crest and measure with a 40 microns micro-CTs. And you can see that the correlation between trabecular strut model index with a trabecular number and trabecular space or BVTV are extremely high, even if you adjust for BMD and previous fracture, which was the purpose of that study. So practically, you have the TBS installed on a DEXA machine, which as of today work on a G Luna machine or a Logic machine. Then you get the DEXA scans, or you have an X-ray. And then within a few seconds, we'll have a processing of TBS. And then at the end, you have a full report giving some information about the TBS information in relation also to the BMD and clinical risk factors, but we'll come back on that. So the TBS have been extensively validated as of today. Really, like just a couple of weeks ago, we have counted more than 800 publications and clearly more than 20 guidelines. But overall, they all say the same now, that TBS is a new predictor of fracture risk independent of BMD, clinical risk factors, and FRAX. It really helped fine-tuning the assessment of fracture risk and medical decision, both in men and women, and especially in gray zone, which means sometimes in osteopenic patient or patient with secondary osteoporosis, which could be diabetes, glucocorticoid-induced osteoporosis, anti-aromatas, HIV patients, chronic kidney disease, and so on, osteoarthritic patient. And for those FRAX, when they're close to the intervention threshold, but I'll come back on that. Another point which is quite interesting is the TBS react differently upon the type of molecule, but again, we'll come back on that. So if you just focus for now on the fracture prediction, you know that slide for quite a while now. It's the first prospective study we published in 2011 with Bill Leslie. This is a big study from Manitoba on more than 30,000 women, and we had more than 1,700 major orthopedic fracture. So what is interesting clearly is a dark red. If you have a low TBS and osteoporosis based on spine or hip, minimum of those two, then you have a very high risk of fracture. Reversely, if you have a low, if you have a normal BMD and you have a high TBS value, then you have a very low risk of having a major fracture. But interesting is this one, where you have osteopenia, so osteopenic patient with a low TBS, you see that your level of risk is equivalent more or less to the average of risk in osteoporosis patient. And that's where we miss a lot of fracture. And that was important because if you start to count them, you will receive that 54% of major orthopedic fracture were indeed osteoporotic, but that means 46 were outside the non-osteopenic zone. And in fact, by applying, for example, osteopenic with a low TBS value as a low zone, you can recapture about 16% of the fracture, meaning you improve the accuracy from 50 to up to 70, 75% as the number of fractures being detected. And that's quite important. And you see that if you have a normal BND and normal TBS, then the number of fractures here is extremely low. So you don't miss quite a lot. So what have been demonstrated, as I say, that is independent of fracts and clinical fractures. So we redid the same study on the Manitoba and also on the individual level meta-analysis, collecting more than 14 different cohorts from around the world, independently of the Manitoba. And the pattern is pretty much the same, meaning that if you have a high probability of fracture and a low TBS, you have even a higher probability, and the same for intermediate step. So we came out with the FRAX group, McCloskey, John Canis and co, that we come with an adjustment factors, where you see here for patient, for example, at 21% of fracture, depending on the TBS value, that patient can be adjusted up to almost 35 or been decreasing to around 14%. So you can see that the younger is a patient, which could correspond to a secondary cause of osteoporosis, the higher the impact of the structure on the FRAX. We also see some impact on the older patients and also on the hip probability, but to less extent on the hip as compared to major pec fracture. So practically, if you have the FRAX tool here with a screen, then you will calculate everything is needed. And you will see here that you will adjust for TBS. So if you don't have the software, but you have the TBS value, by clicking on that button, then you will have a pop-up. You will fill up this, and that will recalculate the FRAX probability, taking into account the TBS value. So whether or not it's impact everybody, the answer is obviously not, because if you have someone with a probability close to 0, even if you have a low TBS, you will not go to the sky with a probability of fracture. So it doesn't make sense. But in average, it will just give you about a 2 to 5% impact for all subjects altogether. Now, if you're focusing more around the intervention threshold, whether or not it's fixed or age dependent, then you have up to 25% of those patients that will be impacted by the value of TBS. Then it's become really clinically relevant and then substantial in terms of number of patients being impacted here. So unfortunately, or fortunately, depending which perspective you want to take, all countries do not have FRAX. Or sometimes people do have FRAX, but you still have the BMDT score, still the primary criterion for osteoporosis treatment initiation because of insurance whatsoever. So what we have developed with Bill Lacey, John Canis and co. is a similar approach to what we have done for the FRAX, but to apply to the BMDT score. So that means, in other words, we're going to do a BMDT score adjusted by the TBS to take the TBS into account, just to combine those two together and give you a better estimation of the fracture risk. So that's something that I will discuss on a report later on. Another important characteristic, and that was presented by Edens, a group related also to Neil Binkley in Madison, Wisconsin. Here with the ICD presented ICD 2021, so just recently. And we've been saying that osteoarthritis doesn't impact TBS. And I know that Neil we're having some doubt at some point. So with this study that he did, we're using a CT scans and a quantification of the scoring from 1 to 6 according to Minura and Patria here, then you can clearly see from that patients that the impact on the BMD is really important, meaning that 25% of the BMD can be almost be impacted by the arthrosis here. And the more severe it is, the higher is the impact. While on TBS, it stays flat, meaning almost no impact of the degenerative score on the TBS, which is confirming a previous study. And that study made by Neil Binkley team was very reassuring for him. So in terms of monitoring, it depends the way you want to see it. Either you see the half full glass or half empty. So other usually, so what we say is respond vary upon the type of molecule, so which is great to know. You will understand why. And the half empty is it's usually less responsive in amplitude compared to BMD, which to some extent also normal, as majority of fracture is being explained by the density itself. But interestingly, you see that depending on the type of molecule here, the impact on BMD and structure per the mechanism of action is quite different. Meaning some of them will improve the density and improve the structure of the bone, like anabolic drugs. If you go for biphosphonate, you're not supposed to improve the structure of the bone, but you will increase the BMD by the degree of mineralization and so on. And quite amazingly, when we do study with different molecules, and this is a summary of some studies, you see that reflecting also in a TBS, where the PTH will both improve the TBS, the structure of the bone, and the density. Denosumab increase the density and also to some extent the structure of the bone, but less than teriparatide. But this is only after 2 years. And I guess that if you prolong that to up to 10 years, then you may still increase and maybe come to a level of PTH. Who knows? Data are being currently analyzed, and you should hear soon about it. Biphosphonate, you increase the density and positive maintenance, while on MHT, then you increase the density and you have like a negative maintenance, meaning that you slow down the loss of the structure as compared to placebo or the use of corticoid or anti-aromatase, which is really have a very strong negative impact on the structure of the bone. Association between TBS and type 2 diabetes. There is also a nice publication here, and also there is position paper from Mario FHO on diabetes. But what is interesting is on the meta-analysis just clearly demonstrated that if you have a type 2 diabetic patient, the TBS will be lower than control, while the BMD will be normal or even potentially supranormal. Okay, but more interestingly, the subject we are in pre-diabetes has significantly lower TBS. And in other words, if you have like a non-controlled glycemic level, then the TBS will be lower, while if you have a controlled glycemic level, then the structure will be about normal, which means that people have to be extremely cautious while reading articles about TBS and diabetes. If you have a diabetic population which is controlled for the glycemic level, then the impact on TBS is not supposed to be that great because it's already controlled. But for pre-diabetic and non-controlled diabetic patients, then the TBS will be extremely low. So when we take all that into account for practice here, then you will see that the 6 steps that we have seen from the CHUV at the Lausanne Hospital will check first quality of the image, determine the skeletal status, take also the BF into account, the clinical risk factors. And then after, when we have the decision, the question will be, should I treat? How should I treat? How long should I treat? So for us is first the quality image check, and that's as you do for the BMDs. The garbage in, garbage out concept still there. You still need to be sure that the edge detection has been done, that you don't have obese patient, that you don't leave fracture vertebrae in the middle, that you exclude them, and many other things as state of the art for the density and so on, whether or not the BMI was in working range and so on. When you're sure about that, then you will characterize the bone structure per threshold given from the meta-analysis of these 14 different cohorts and published by McCluskey, where we have above 1.31, then we can consider that as compatible with a normal microstructure. If you're between 123, 131, it's partially degraded microstructure, and then below 1.23 or equal, then it will be considered as a degraded microstructure. But then the next step is to really people to understand what the structure. But when we talk about the structure, it's interesting because patients tend to understand better what a microstructure is compared to the density itself. And the analogy that was used by Neil Binkley again here is the scaffold analogy, which is actually turned to be very useful when discussing TBS and treatment benefit risk with the patient. Apparently, they understand that much better than the concept of the density, which still appear to be vague for patients. Few important things to know in terms of skeletal status. We can have people with a normal BMD, but they still have major bone loss or low TBS. In other words, I will give you a clinical example after. You may end it up with a patient that is a normal BMD, but then may lose like 20 or 30% of the BMD and still be normal after that. But the fact to lose so much loss put the patient at risk and increase the risk of fracture, as we'll see. Conversely, you may have low bone density, but normal TBS. And that, for example, especially true in petite or small people, where in small people, because it's areal density, the density tend to be totally underestimated. So you tend to have a low density for those most people, while in fact it might be about normal. So it's mostly artifact-like. And sometimes what we have demonstrated here in a nice paper published by Neil Binkley and Bill Leslie and myself and some other colleagues in 2020 last year, is that in fact, when you combine the BMD and the TBS, you really have rare case where the fracture patient have a normal, really normal cases. And that's interesting because we can see here that a prior fracture, if you use only low density, like a normal, according to WHO definition, normal density, you will have about 11% of the fracture occurred in a normal zone, but or 10% for major fracture. But then if you combine with the TBS, it will drop from 11 to 6% or 5% here. Now, if you take the incident fracture, then that's even more, because if you consider only the normal density, then you will have 9% of the major fracture, for example, or fracture, that will be normal BMD. But if you combine with TBS, it will be only 4% or even 3% if you consider major fracture. So having all that, the next step for us to interpret that will be the combination of the BMD and TBS. So we define here certain zone of risk. So just to avoid the confusion with FRAX, we'll call that bone resilience zone. The bone resilience index will be defined as the combination of the BMD T-score and TBS categories to some extent. So the zone of bone resilience are established based upon the level of fracture risk that we have calculated from Manitoba or some other studies. So the bottom line is, if you have a patient with a BMD T-score, which is osteopenic and degraded TBS, which is in this zone, then you will be in a low resilience zone, meaning a certain higher risk of fracture to some extent, not as if you were in a red zone, but at least sufficiently worrisome to think about it. So the question should be, is it normal for age? Is it a known secondary osteoporosis? Is it undiagnosed vertebral fracture or known diabetes or pre-diabetic? So all those questions should be in your mind when you have such a result. Then should I treat? Then you have two options, actually three. Either FRAX, either BMD T-score adjusted, or combination of both. The first one is you will use here, you will have in the report, for example, the FRAX, which could be here adjusted by the TBS. And if you have FRAX adjusted by TBS, that the value will see whether or not it's above the intervention threshold as defined by your country. So if it's above your osteopenic, but with a FRAX adjusted by TBS above the intervention threshold, that you might seriously consider to treat the patients. And then you can follow the treatment pathway developed by IOF and been published by John Canis a while ago in 2019. Obviously, if you have osteopenic and major prevalent of fracture, you should treat irrespective of the TBS and FRAX value. So if you don't use FRAX, but you use a BMD T-score, then you may use the BMD T-score adjusted by TBS. And the same, if you're, for example, in an osteopenic zone, but the BMD T-score adjusted by TBS bring you to a osteoporotic zone equivalent, then you may seriously consider to treat your patients. So what about the treatment? So you remember that depending on the type of treatment, you have a different profile. So this is a bit provocative, but for the concept is very interesting because you want to treat the patient for the best benefit of the patient. So obviously, if you know that your patient here, for example, in osteopenic with a high risk of fracture, which is equivalent to what you see in osteoporosis, but is related to both the density to some extent, but even more by the structure, then you want to have a treatment that will impact both the density and the structure. So giving a biphosphonate, that will be good for the density, but not so much for the structure. So if you don't want to go with a PTH, which will not be relevant, except if you have vertebral fracture, but here, if you're osteopenic with a low structure, then the treatment option will be for us, will be denosumab, for example. But that you can either use a combination of fracs. So that means if you're osteopenic, and then you have the TBS fracs adjusted by TBS or BMDT score below the intervention threshold or below minus 2.5, then you may decide to treat and then choose a treatment according to the category or profile of risk in which the patient stands. So then you have the treat to lower. How long should I treat? That would be treat to lower risk zone or treat to a higher resilience zone. And the idea here is just to see how long you should treat the patient, because you may have a patient here which has a very high risk zone of fracture or very low resilience zone. And then the patient say, I don't want to take teriparatide or PTH in general. In that case, he may even say, I don't want to take denosumab. I just want to take a biphosphonate. Good, okay, that's your call. But then you will have to treat much longer because you will mostly influence the density and not the structure. So that means the path to go out of the high risk zone or low resilience zone will be much longer. And every time you change zone, then you will have to reconsider the way to do things. So now with a new report, everything I mentioned is completely embedded into one single report that can be done. So this is fake data, obviously, but it gives you an idea about what can be done in a new report. So a few cases, and I will end up that. Here you have a lady close to the treatment threshold for US. So you have a 65-year-old woman whose mother sustained 4 vertebral fracture, first at the age of 68. So that means historical fracture in a family, direct family, generally healthy, no other fracture risk. And the BMD for the spine is about minus 1.8 T-score. So like osteopenic. And the examination laboratory is unrevealing. So according to US guidelines, no treatment. Now the patient got the TBS and the TBS was very low. And actually, if you recalculate the fracs, you move from 18 to 21, 1.2 to 1.7, but 21 is above the threshold of 20 per the US guidelines. So that means it will be an indication for treatment for that patient. Another case here where you have a 56-year-old woman. She's 1.5 meter and a weight of 43 kilograms. So she can consider as a petite. And she's osteoporotic according to femoral neck. No other clinical factor, VFN negative. Probability of fracture is 9.8, so fairly low. They say, oh, she's osteoporotic, but probability of fracture pretty low. What about the TBS? Well, pretty high, so pretty good structure. So in that case, here's a case of Neil Binkley. Despite the T-score osteoporotic, she's at low risk and has a normal TBS. So in that case, Neil didn't recommend medication for that patient because he knew that it was underestimation of the density because she was petite. Another case here, like a normal BMD, but the patient have a huge loss between 2 times. So he was 65 years old, sustained a vertebral fracture with a lifting window blind. So the current DXA was about okay, minus 0.8, minus 0.8, nothing to worry about it. But what is worrisome is that a couple of years before, she was plus 1.7, plus 1.8. In other words, she had 21% and 27 loss over like 15 years, which is quite a lot. But by measuring that patient, she was extremely low TBS again. So that means from that patient, because of a major loss, even though it was a normal, the fact we have a loss, important loss between visits and also low TBS, that person was considered for a preventive treatment, at least to avoid well, not preventive treatment because she got vertebral fracture, but she's been treated appropriately. So here in the last case, I will end up on that one, is a 62 years old female, no fracture, smoker, corresponded checkup for osteoporosis, so osteopenic, and revealing problem with the lab and a clinical test, and the TBS was degraded. So clearly that patient was in an osteopenic zone, degraded, so kind of a high risk of fracture or low resilience zone. So we searched for secondary cause of osteoporosis, and that patient was at HbA1c was at 6.9, so really like pre-diabetic things that was discovered, and actually that will have explained. So the probability was under the Fraxis intervention, and then the BMD then was just at minus 2.5 by taking the TBS into account, and that means we enter into the algorithm of management of a diabetic patient, and then treatment was considered for that patient. So the whole idea will conclude here, the BND plus TBS per clinical refractory or FRAX or whatever other model. The idea is not to treat more, but to treat better those really are in need, and always take into account the clinical context of your patient and trust your judgment. And I will end with this. Thank you for your attention. Even if you do not see, sometimes structure really matter. And most importantly, I really would like to end this lecture with a message for Neil and I, where we just say to our friends, rest in peace, our friend. We will miss you for sure, but we will never forget you. And that pictures was taken in a nice restaurant with Professor Porovnyuk in Kiev in October 20, 2016, where we have a good moment with him and his friends and colleagues, as we always did. Having said that, thank you very much for your attention. So if you have any question, I guess we can go from there.